This is a focused case study on postpartum depression. I will begin by talking about the learning objectives, then I will give some signs and symptoms of postpartum depression, and then increased risk factors for development of postpartum depression. Learning outcomes. 1. Identify risk factors associated with postpartum depression. 2. Identify signs and symptoms of postpartum depression. 3. Understand assessment methods and tools used to assist in the diagnosis process. 4. Understand how to plan and adjust care as it relates to the treatment of postpartum depression in this patient. Here are some signs and symptoms of the various illnesses that new mothers may experience. You can read them on your own, and I'm going to discuss them a little bit with you. Postpartum blues is fairly common. It affects nearly 80% of women during the first few days following labor and usually resolves on its own within 2 weeks. If the symptoms do persist and worsen, the mother may need evaluation for postpartum depression. Postpartum depression has a 3 to 6% overall prevalence rate. In addition to the postpartum blues, has an overall more severe versions of them, a lack of interest in previously enjoyed pleasurable activities, thoughts of inadequacy as a parent and individual, difficulty concentrating or making decisions, and also they can have insomnia or excessive sleeping. Postpartum psychosis is a rare but serious complication from untreated postpartum depression. It is considered a medical emergency, includes agitation, hyperactivity, insomnia, delusions, hallucinations, poor judgment. It affects 1 in every 500 to 1,000 deliveries. They have a high risk of suicide or infanticide due to irrational thought processes initiated by the delusions and hallucinations. Assessments can be challenging in this population due to lucidity seen in some psychotic patients. Here are some factors that increase the risk of developing postpartum depression. A history of mental illness, including depression, bipolar disorder, previous postpartum depression, and other mental illnesses. Premiparity, which is a first pregnancy. Ambivalence, which is conflicting feelings about maintaining the pregnancy. A lack of social support, either parents or partner. And a lack of stable, supportive relationships, including the parents and the partner as well. A lack of supportive relationship with her parents, especially her father as a child. And dissatisfaction with herself, including negative body image and eating disorders. Now that we have been over signs and symptoms and risk factors, we're going to look at a case study on an individual young woman. Alyssa Grant is a 24-year-old Caucasian female who was brought to the emergency department by her younger sister today. Now, we're going to take a look at a history of the presenting problem, her personal social history, and her medical history, all at first. She has been feeling increasingly low moods and high anxiety levels for the past 3 weeks. She is a first-time mom who gave birth to her son 6 weeks ago. She says that she did not feel that overwhelming joy following his birth that she thought she was supposed to and thought it would eventually come to her. But her symptoms kept getting worse. She stopped talking and returning phone calls and other communication with her friends and family about 10 days ago. Her sister became concerned, went to her home to check on her, and convinced her to seek professional help. She does not remember the last time she showered or brushed her teeth and has not cleaned her house since arriving home from the hospital. She says she cries all the time and feels like she is in a fog. She says she wants to just be happy and enjoy her son but cannot seem to snap out of it. She lives alone with her 6-week-old son. She was not married to his father, and he unexpectedly broke things off with her when she was 30 weeks pregnant, and she has not seen or heard from him since. Her son was born full term after an uncomplicated pregnancy and birth. The baby is breastfed on a regular feeding and sleeping schedule. She has active relationships with her mother, brother, and sister who live in the same city, but has not spoken to her father in 15 years. She has a group of friends that she normally socializes with on a regular basis. Alyssa's mother has suffered from depression for a long time and manages it with medication and therapy. Alyssa denies having any depression or anxiety herself. Since the patient's medical history reports that she's healthy with no previous illnesses, she's a non-smoker, occasional social drinker who quit during her pregnancy and hasn't started back since, and she only reports taking acetaminophen as needed for aches and pains and headaches just a couple of times a week. We're going to go ahead and link her present problem with her personal and social history. We can start by assuming that Alyssa experienced the postpartum blues after the birth of her son, and that's why her moods have been increasingly low and her anxiety has been increasingly getting higher. She has significant personal history to increase the risk factors of developing postpartum depression from the baby blues. She's had a traumatic experience with her child's father while she was pregnant. Her mother has a history of depression. She hasn't had any contact with her father for a very long time and didn't have really much contact with him as a child. She's a first-time mom, and she just has not been feeling well. She can't remember a lot. Everything's going kind of bad for her right now, and she just can't seem to get out of it, and she doesn't understand why. Now, there's nothing in her medical history that indicates anything personally. So we have to move on to the next section that will discuss the assessment data that we received from her physical assessment. And this is to see if any of her physical assessment data correlates to her history of data that we have collected as of right now. Now to review the assessment data. Her vital signs were blood pressure 110/70, temperature is 98.3 degrees Fahrenheit taken orally, heart rate is 87 beats per minute and regular, her respiratory rate is 16 breaths per minute and regular, her oxygen saturation is 99% on room air, and she denies having any pain. The abnormal findings found during the assessment was that she struggles to make eye contact, is slow to answer questions, she has poor posture and is visibly distressed when speaking, she has poor body hygiene, she has poor skin trigger and slightly dry mucous membranes, she has excessive sebum and red itchy patches on her scalp, and her hair is oily and matted. Now we're going to give the rationales to each abnormal finding for her physical assessment. Avoiding eye contact is related to the depressive state the patient is experiencing. She has feelings of shame and guilt associated with the perceived stigma of her behavior due to the illness. So being slow to answer questions is also related to the depressive state, her low self-image, and presumed lack of sleep. Having poor body hygiene with excessive body odor present is related to the inadequate self-care and inability to complete her daily tasks. Disheveled, unclean clothing is due to inadequate self-care and also the inability to complete her daily tasks. Dry mucous membranes are a reflection of the client's hydration status from inadequate fluid and nutritional intake due to her depressive state. Excessive sebum on scalp, matted and unclean hair, and red patches on scalp are also due to inadequate self-care and the inability to complete her daily tasks. All her vital signs were normal, so there's no need to give rationales for that. With the assessment data in hand, her vital signs are normal, and the abnormal findings of the physical assessment with rationales, we can link it to the original interview with the patient's history of the presenting problem and her social history, and conclude that we need to do an in-depth client evaluation. But first, I'm going to go over the nurse's role and the tools used during the patient interview. Nurses' roles during the interview include gathering information, observing the patient's voice and body language and how they correlate with each other, using therapeutic communication to facilitate an open and trusting relationship between the nurse and patient, reassure the client of her support system, and then to use the Edinburgh Postnatal Depression Scale as a tool to further assess the patient. And once the assessment is complete, you will report the findings to the provider for him to analyze and come up with a treatment plan. Here's an example of what the Edinburgh Postnatal Depression Scale looks like. It is a self-assessment tool for the patient to enter responses. It is very valuable and significant diagnosis improvement in patients with postpartum depression. It is often used in conjunction with the postpartum depression screening scale. That's 35 items, and it screens for postpartum depression signs in different categories of assessment. During the patient interview, the nurse begins by asking the client about her home life. She states that she lives by herself with her infant son. She also states that the baby's father just up and left without warning when she was 30 weeks pregnant. He changed his phone number and has not been in contact since then. This made her very upset for the remainder of her pregnancy, but she had the support from her family and friends to help her overcome this and regain control over her environment. When asked if she mentioned this event and how it affected her to her obstetrician, she said she did not because she felt like she had it under control at the time. The nurse then asked her questions about the birth of the baby, and the client said that her mother and sister were present during labor and delivery. She received an epidural and had an uncomplicated vaginal delivery. When asked how she felt when she first held her son, she said, "Nothing really, not the joy I thought I would." She also related that she assumed this was due to her being really tired because her labor was long, almost a whole day, and assumed she would eventually feel it once she got some sleep. When asked how the baby has been at home, the client said he has been sleeping and feeding normally, and she breastfeeds both from the breast and pumped milk from a bottle. She also said that even though she knows he is doing well and very healthy and happy, she feels very overwhelmed and exhausted with the responsibility of caring for him. She says this includes being too exhausted to cook for herself or perform household chores, so her house is a mess and her diet is made up mostly of snack foods and pre-made items. When asked about her appearance, the client says she is too scared to leave the baby to shower and thinks something bad may happen to him if she cannot see him. So she hasn't showered in probably weeks and says she feels like she is not capable of taking proper care of him by herself and fears she will do something wrong. She states that even though her family has been trying to contact her and even offer to help her, she has been avoiding contact because she feels ashamed of herself and doesn't want them to see her like this. The nurse assures her that her family will not judge her and that it is important for her to ask for help if she needs it. The nurse tells her that it is normal to feel overwhelmed as becoming a parent is a huge change in her life, and it takes time and a good support system to adjust to the change. The nurse tells the client that from her description, it looks like a good support system is there and all she needs to do is accept the support. The client agrees, and the nurse tells her the physician will begin to ask her a few more questions and we will work together to figure out a plan for her. It is important to note that during the assessment, the nurse should be noting the patient's body language and if it relates to what she is saying. With the patient's signs and symptoms, it's important to get certain lab data to rule out any underlying causes like an underactive thyroid or possible anemia. So the physician runs blood tests to make sure all of her levels are normal. And if you look at the levels of her blood tests and compare them with the normal levels, they all fall within the normal range, so she is not, in fact, suffering from a physical problem. So we need to proceed with treatment planning for the postpartum depression. A quick recap. We have linked the history data, assessment data, and client's vital signs and lab work to do a preliminary diagnosis of postpartum depression on the patient. So the provider did diagnose the patient with postpartum depression. That was due to all this data, and her family's history and her history of the trauma with her baby's father abruptly leaving during her pregnancy. He discusses with the client her treatment options, and the treatment plan is as follows. Now, her medical management. After completing the psychological evaluation and using the Edinburgh Personal Depression Scale results filled out by the patient, the provider orders the following medications. Sertraline, 25 milligrams by mouth daily. This is an SSRI. It's for antidepressants. Some of the major side effects are suicidal ideation, and it may transfer to breast milk. And some important education information is to not take more than directed, report any worsening mood symptoms, and immediately send them to your doctor. The normal saline IV drip is to maintain the fluid levels and prevent fluid volume deficit. Major side effects are fluid overload, hypernatremia, and hypokalemia. Important things to note is to weigh self daily using the same method and report any weight gain of 2 to 3 pounds within a 24-hour period. Promacare 1 was the prenatal vitamin ordered, and it's pre- and postnatal use. It provides needed supplementation for lactating mothers and to improve their nutritional status. Contraindications include hypersensitivity in patients sensitive to the ingredients, iron overdose if not taken as prescribed. The only instruction is to take as directed until no longer lactating or needed. For a little more detail on what the nurse will provide during the hospital stay for the patient, here are a few things. She'll provide therapeutic communication throughout the patient's hospital stay. She'll administer medications as ordered and provide education on all medications to the patient as necessary. Closely monitor her for any unusual behaviors or negative changes not noted in the initial assessment. Observe any interactions that may occur between the mother and the baby as appropriate to assess parental abilities and attachment to the baby. She will also provide discharge teaching that includes the importance of adhering to her medication regime and following up with the specialist in postnatal mental health provided to her. They also provide teaching to her family on what to look out for at home in relation to possible worsening of symptoms or reactions to medication and when to seek immediate intervention. These nursing actions also prevent the patient from getting complications such as postpartum psychosis and leading to possible suicide, and have the patient's safety in mind. Some client teaching related to the priority nursing diagnosis includes the following. First, to identify the priority diagnosis, which is situational low self-esteem related to her depressed state as evidenced by the client's self-evaluation of inability to cope. This is also along with the objective and subjective assessment data and everything else. What the nurse would do is ask about strengths seen in the patient and herself and ask her to identify her outcomes that she desires with treatment and to strategize on working together to achieve her goals. And this is to be done on the patient's time and when she is ready and available to learn and collaborate. You should regularly check in, reevaluate her mental health status, always use therapeutic techniques. Ask about any prior knowledge to the medication prescribed. Does she know anything about any medicines? If not, you would explain in detail and then answer any additional questions she might have to ease any anxiety related to taking the medications. Ask if she has any knowledge of community resources. If she does not, identify them with contact information and be as detailed as possible to reduce any stress related to not knowing how to go about making any of these contacts. And prior to discharge, you would educate on everything on medications, seeing mental health care professionals, when to seek help, following up. Now, for the priority nursing intervention related to the priority nursing diagnosis just taught to the patient, we're going to explain to the new nurse. Now, we're going to identify client's basic sense of self-image, existential, physical, and psychological, which will create a baseline of the client's image to have a benchmark to compare future evaluations with. This improves patient care by being able to quickly identify changes in the patient's mental health that may require changes in care plan or immediate interventions. Doing all of this requires building a therapeutic relationship between the nurse and the patient. The patient has to openly and truthfully communicate for effective nursing interventions to be implemented. So it is important for the nurse to herself be educated on therapeutic communication and nursing diagnosis and how to create a safe and effective patient care plan. Now, the treatment plan in the hospital was effective. Alyssa was discharged home and scheduled for a 5-week home visit evaluation to follow up on how the treatment has been going. Now, she has been taking the sertraline with no unwanted effects and states she feels like herself again. Her walk is normal and she's eager to show off her home and baby, now 11 weeks old. She is still breastfeeding and her son is gaining weight and developing on schedule. Her psychological state has obviously improved since her visit to the hospital, and her appearance has significantly improved. She is in well-fitting clothes, styled hair, and her skin is glowing. She says she has never felt better and is totally in love with her son. She still has had no contact with the father, but has been giving all of herself to the baby, and her family and friends visit regularly. She states that her mother and sister went to her home before discharge and cleaned everything, making the house spotless. She said that decreased her anxiety as soon as she returned home, and the regular visits from them to assist with the baby and help to tidy up kept her well enough until the medication took effect, along with weekly counselor visits beginning 4 days after discharge. The medication and therapy treatment are proving to be effective in this patient. She states that she plans to attend group support meetings once a month in addition to her individual sessions because her counselor thinks it will benefit her further. Now, in this patient, when the original therapy seems to be working well, why would she change it up and add something else in? This is due to the fact that being in a group meeting helps her develop more of a sense of belongingness by being with people who are going through the same thing and are able to share stories, so she knows that she is not alone in what she's going through and can be beneficial to mothers in many ways. Now it's time to take a short quiz to evaluate the learning outcomes presented at the beginning of this presentation. You're going to need a phone or other device to access the website or app to take the quiz. I'm going to need you to enter the code below to begin the quiz. As soon as everyone's in, it will start. Question number 1. What major life event noted in the patient interview put her at risk for development of postpartum depression? A. Her sister kept calling and texting her. B. The loss of a romantic partner during her pregnancy. C. She received an epidural during labor. D. She did not feel joy when first seeing her son. All right, on to the next one. What sign immediately after delivery indicated possible postpartum depression? Her mother and sister were present. She was really tired from long labor. Apathy, which is no feeling towards the baby after his birth, or breastfeeding. The correct answer was apathy. Great job. The patient's disheveled appearance and other evidence of poor hygiene indicate what? She is too lazy, unable to perform self-care activities, the baby takes up too much time, or her water got turned off in her home. That's right, she's unable to perform her self-care activities. A thyroid function test is performed to evaluate underlying causes of the mood changes in the client. True or false? The answer is true. Why is careful consideration taken in this patient when selecting medications for her? She is sensitive to medications, some medications cause dependence, possible drug-drug interactions, or she is breastfeeding. She is breastfeeding. True or false? The Edinburgh Postnatal Depression Scale is filled out by the healthcare provider. The answer is false. It is filled out by the patient. Why is a prenatal vitamin prescribed to the patient? She may be pregnant again. The physician prescribes them routinely for all patients. They are recommended for lactating mothers. It aids in effectiveness of antidepressants. Providing external resources for support will only overwhelm the patient and is not beneficial in the healing process. True or false? That answer is false. All right, this time is select all that apply. What are possible complications of untreated or poorly managed postpartum depression? Postpartum psychosis, schizophrenia, adverse reactions to medication therapy, or development of diabetes. Postpartum psychosis and adverse reactions. Why is newborn development a concept of concern in this case of postpartum depression? The child will develop depression. The infant will not be taken to the doctor. Self-care deficit may lead to infant care deficit and has nothing to do with postpartum depression. The answer is self-care deficit. Thank you for taking the quiz. I hope you enjoyed it and I hope you learned a lot from this lesson.